What did you think? Or what did this video bring out for you?
So this was indeed a video of Professor Anderson performing gastroscopy. I think the woman had dysphagia, dyspepsia, and the main focus was on the technique of how, from the start till the end, use the scope in a correct way, with mainly focus on the more difficult parts. Certainly, when you start endoscopy, the introduction, I think, is not very is difficult at start, so it starts already there. Then the GI junction, how to assess the stomach, pulse the pylorus, and have also proper introduction in the duodenum. I think it all covers those sections on how to do and optimize your technique.
Well, let's talk a bit about the pylorus. So maybe we ask Anika and we ask you, so I'll ask Anika about a separate part, but what did you learn from this video about the pylorus? So what did you take away from it?
As we will see, it was not very, he was more contracted, more in spasm. It was not very open like we saw in the previous live cases earlier. And when pushing, trying to go forward, you pass or it flips away. So Professor Anderson explained that it's also because the scope makes a more loop in the greater curve. And by just sitting there using the small wheel, pulling a little bit back and waiting, it might open up and you might just fall into it.
Anika, what did you take away from the part about the duodenum and how to stay in the duodenum?
You have to make sure that you always see where you're going. And then follow the direction of the duodenum. Mostly it's a turn to the right. You have to use your wrists actually to turn.
Left wrist, yeah.
Your left wrist. Turn the scope, and then fall in the lumen. And then when you want to go further, you have to pull back and torque a bit so that the loop in the stomach straightens. You can go further in the duodenum.
And then, Jolien, why don't you tell us what you learned about the gastroesophageal junction from this video?
First you do complete step up so you can make the turn. And I always tend to torque, I think anti-clockwise, just to fall into the corpus and the fundus. But what Dr. Anderson made clear was also, and this morning actually as well, unconsciously, you have to turn also the hand that's holding the scope. And by those movements, you can already see a lot more, because I thought I was using also more the little wheel, but I think it's not really necessary to inspect the GI junction and the fundus, but by using your hand you can already see a lot of it, and then it's just fine-tuning with a little bit with the buttons. That's
wheels.
So what I try to do in those videos is deconstruct what I'm doing. So if you watch them online or on the website, you'll see that they've got an accompanying audio, which is really explaining the technical aspects of what I'm doing and why things work and why things don't work. And this was just a normal list of patients. If you want to look at the timestamps, it was just one patient after another on a routine list. They weren't necessarily specially selected.
Just for the next case, it will be Delphine doing the cases. So I don't know if they're ready. I don't think they're ready, but when they are, maybe you can take off into the room and I'll join you, and we'll let Lobke do the comparing in here for a little bit. And then David, I also like in one of the cases this afternoon, would like you to show us how you do a gastroscopy, because I do think that you'll get my opinion. You've had John's multiple opinions on the website. You've had Lobke's opinion. And then you can integrate, because it shouldn't just be one of us says, it should be you take the best things of the people that you observe, people who are doing a lot of gastroscopy, and you take the best things for your practice. That's my intention.